So I would like to introduce a little bit our next speaker. She is Jessica, and I'll just give you a little bit of an intro with her. So Dr. Jessica Hafner is a consultant neurologist at the Central Adelaide Local Health Network, and she has a special interest in peripheral neuropathy. She completed a neurophysiology fellowship at the Royal North Shore Hospital and currently runs the complex neuropathy clinic at the Queen Elizabeth Hospital. She is currently the primary supervisor for the Central Adelaide Local Health Network Neurophysiology Fellowship, and she has a very keen interest in teaching and quality assurance. So let me hand you over to her.
Thank you very much. I'll just get started. We've only got half an hour and I've got a little bit to get through. So I've been asked to talk to you today about myeloma-related neuropathy, particularly with a focus on what you might be able to do about it. So firstly, what is neuropathy? What are the types? Why does it happen in people with myeloma, and how is it diagnosed? And then I'd like to focus most of our time talking about how we can prevent it, how we can manage symptoms, and then just touch on what research is happening in this space. So just very sort of basically, peripheral nerves are a part of our body that carry electrical signals to and from the brain and or the spinal cord to give us information about sensation, to help us move our muscles, and then also to control other bodily functions, such as Hannah was saying, our gastrointestinal muscles, and also our bladder muscles, blood pressure, heart rate, and sweating are also controlled by nerves. And peripheral neuropathy just is a term that's sort of all-encompassing and refers to any condition in which those nerves are not working properly. And that can be in various forms. So you could have just a sensory neuropathy affecting the nerves that conduct messages about sensation, or a combination of sensory motor on its own, or sometimes involvement of those autonomic nerves that control bodily functions. And I just thought I'd also mention the terms large fibres and small fibres, because I'll refer to those later in the talk. So large fibres are named so because they're physically larger, they're thicker, and they carry information about touch, joint position and vibration. And small fibres are smaller, obviously, and they carry information about pain and temperature. And that's just relevant because sometimes in myeloma, people can have one type of fibre affected more than another. So in terms of the symptoms, it depends which of those nerve types is affected, what the symptoms might be, but just very briefly, people who have small fibre neuropathy will get symptoms like numbness, pain, and nerve pain is classically sort of a burning or even like an electrical type pain, very sharp, often very painful, and also can get tingling and hypersensitive skin that sort of feels painful when you touch it, and the type of touch wouldn't normally be painful. People who have involvement of their autonomic nerves have symptoms associated with some of those functions not working properly. So getting dizzy when they stand up, having trouble with constipation or diarrhea, trouble with emptying the bladder, dry eyes, dry mouth, impotence in men, and also feeling full or even sometimes vomiting after meals because their stomach's not emptying normally. And this can then lead to weight loss. People don't tend to complain of a lack of sweating, but it's something that as a doctor interested in neuropathy, I often inquire specifically about. And then large fibre symptoms, again, numbness and particularly that sort of difficulty with joint position. That's how our sort of legs tell us which way we're standing. So when that doesn't work, we tend to lose balance. And then if it's affecting the nerves to the muscles, we can get muscle cramps or even weakness or wasting of the muscles. And then often, particularly in amyloidosis, which we're not talking about specifically today, but often is related, carpal tunnel syndrome is very common, and that involves one of the nerves in the wrist being sort of damaged particularly, which can cause hand symptoms. And then also in amyloidosis, it's possible to also get muscle symptoms unrelated to nerves. And the reasons that people with myeloma and amyloidosis get neuropathy is actually quite complicated. It's not a simple single problem. It can be from the paraprotein itself in myeloma and in AL amyloid, which can be directly toxic to the nerves. Also, if you've got very high levels of paraprotein, your blood can be sort of sticky or viscous and not flow through blood vessels as easily, and therefore your nerves don't get as much blood supply and oxygen as they need, and that can cause damage. Myeloma bone disease, if you've got a nerve sitting very close to a bone and then you get a bony lesion right adjacent to it, it can expand and sort of stretch or crush the nerve. Having a form of cancer in general, and myeloma is no exception, can cause weight loss, which we actually rely on some of our adipose tissue, our fatty tissue, to protect and pad our nerves from compression. So when we lose a lot of weight, our nerves are more vulnerable to being crushed or compressed. And also, as Hannah was talking about a lot, having nutrient deficiencies in cancer and cancer treatment can also be a big problem for nerves, which rely on quite a lot of different nutrients to function well. Also can be more vulnerable to certain infections, such as the shingles virus, which sort of tends to get into and damage nerves. And then also the treatments that are used in myeloma and in AL amyloid can also increase the risk of neuropathy, particularly bortezomib, which can be directly toxic to the nerves, or less commonly actually cause the immune system to sort of malfunction in a way that causes it to attack the nerves. Thalidomide can also cause neuropathy. We don't really understand why that happens at this stage. And then vincristine, which is not used very commonly in myeloma, is well known to be quite toxic to nerves. And then, of course, the common things that cause neuropathy in the wider population can also affect people with myeloma. So things such as diabetes, excessive alcohol consumption, and vitamin deficiencies, particularly B12, can contribute. So in terms of what you will be looking for if we're examining you to work out if you've got a neuropathy, we'll be looking for those things I mentioned. So is there loss of sensation? Is there a drop in blood pressure? Is there difficulty with feeling joint position, losing reflexes, and looking at muscle wasting? They're the sorts of things I look at when I'm trying to diagnose a neuropathy. And then we also might do some tests and nerve conduction studies, which some of you may be familiar with, where we put sort of electrical pulses through the nerves and measure how well they transmit those electrical pulses. That's a very useful test for working out where the problem is, what type of problem it is, and how severe it is. In people who are having symptoms of autonomic neuropathy, so difficulty with, feeling full or feeling dizzy when standing, there are some specific specialized tests to look at those. So gastric emptying studies and urodynamic studies, which look at how the bladder is emptying, and tilt table testing, which is a sort of testing whether your blood pressure and heart rate do what they're meant to do when you get tipped from lying up to standing. And we also obviously will look for things that we could treat, so things that could be causing neuropathy or worsening neuropathy apart from myeloma and treatment. So testing for diabetes, testing for B12 deficiencies. And then in some situations, if the neuropathy looks a bit strange or unusual or not what we're expecting, we might do some additional testing, such as testing spinal fluid or even urine samples, to look for a less common cause of a neuropathy, which might require a different specific treatment. Sometimes, but not always, and actually not even often, if we're very concerned that there's a problem with the nerves that we haven't really got to the bottom of, we might take a biopsy of the nerve, where we look at a piece of nerve under a microscope. It's actually the only way that we can definitively confirm that someone has an amyloidosis-related neuropathy, but it's a procedure that's not without risks. It can cause obviously, it will cause a patch of numbness because you remove the nerve, and some people will also get post-operative pain afterwards. So we don't do it unless we think there's really no other way to work this out. And if somebody has known myeloma or known AL amyloidosis, we generally wouldn't need to go to the nerve to confirm the diagnosis. So does everybody who has a neuropathy need to see a neurologist? Well, it's a tricky question, and I think it really depends on access. And I'm not sure where everyone I'm speaking to today is based, but here in South Australia, we have a very substantial sort of supply and demand mismatch with our neurologists, and there's a lot of people who would benefit from seeing a neurologist, but not enough people to see them. And so, unfortunately, in South Australia, we're really restricted to seeing people where we think we're going to add the most value to their care. And if there are other options, then we try to support general practitioners and physiotherapists to care for our patients with neuropathy without necessarily needing to see every single person. But certainly, if people are having difficulty walking or difficulty with their balance or muscle weakness, or their neuropathy is getting worse quite quickly, those are the people that definitely need to come and see us. And the reasons for that is that we can confirm what the diagnosis is, make sure that we're not missing something that needs a different strategy for treatment, making sure we pick up any neuropathies that are potentially treatable. And then also we like to help to guide with any symptomatic treatment. And often we sort of collaborate and work with general practitioners, hematologists, oncologists, pain specialists, and of course our allied health colleagues, physiotherapy, occupational therapy, and dietitians to sort of support patients with neuropathy going through that, even when we can't necessarily fix the neuropathy, for want of a better term. So what can we do then to prevent treatment-related neuropathy? So this is the neuropathy that occurs due to the treatments that are used to treat myeloma. And this is really tricky sometimes because it's a little bit of a catch-22 in that to prevent treatment-related neuropathy, obviously if you didn't use the treatment, you wouldn't get it, but the treatment is needed for the myeloma, which has its own issues, of course, as you all know. So the things that we can do is promoting nerve health. So if a person with neuropathy also has diabetes, then a really good focus on good control of their blood sugars goes a long way to supporting their nerve health. Avoidance of alcohol, and in most situations, this doesn't need to be complete abstinence, but certainly alcohol is toxic to nerves, and if it's being consumed excessively, can contribute significantly to worsening neuropathy. Smoking cessation has lots of advantages, and if we're wanting to make sure our nerves have good blood supply, then stopping smoking is essential. We want to make sure we diagnose and treat any vitamin deficiencies that might exist, and maintaining a healthy and nutritious diet will ensure that those deficiencies don't recur. Some of the medications that are used in myeloma are sort of non-negotiable, and obviously if people have a severe neuropathy, we want to have a look and say, is there anything that we can change here that will improve the chances of this neuropathy not progressing to be something that's significantly disabling. And so sometimes hematologists will review doses and change regimens to reduce the risk of that severe progression. But obviously that needs to be weighed against the risks of potentially less effective myeloma treatment as well. And that's quite often quite a complex discussion that needs multiple people kind of working together, including, most importantly, the person receiving the treatment, to weigh up the pros and cons and what's important to them. There is a fair bit of research out there around, is there something we can do to prevent treatment-related neuropathy? So when we know we're going to be giving somebody a medication that could cause a neuropathy, is there anything we can do to reduce the damage. And it's a bit unclear. People have looked at various sort of therapies about temperature control and compression and various medications and agents. And at this stage, there's not anything that is clearly in favour of doing those things related to myeloma medications that are used. Some of the other chemotherapy agents used in other conditions, there seems to be some things that we can do to reduce the risk of neuropathy, but in the myeloma space at the moment, nothing's yet been proven and in routine practice. So then if we do have neuropathy, what can we do about the symptoms and how can we minimise the impact that it has on our lives? The biggest issue, I think, often is neuropathic pain, and this is a really tricky space because a lot of the medications that are used to treat neuropathic pain have lots of side effects and also aren't sort of excellent in their efficacy. So I always talk to my patients about non-medication measures, and pain's really complicated. It's not just a biological process. It's so closely intertwined with our own sort of social and psychological and physical well-being. And the way our brain receives and interprets messages about pain is something that we're still growing our understanding of it. But there's lots of really good scientific evidence now that looking after those sort of social and psychological and physical well-being aspects goes a really long way to reducing the impact that pain has on our lives and the disability that pain causes. So I really encourage patients to think about those things and actively try to address them. And this is things like staying active with your family and friends and engaging in activities that give you meaning and things you're passionate about, practicing relaxation and mindfulness and doing attentional techniques. So diverting attention away from pain will reduce the amount of sort of volume that you're I often think about it like turning a knob on a radio, and we want to turn down the volume on the pain signals coming into the brain. And um, diverting your attention away from it, and that's obviously not very easy when you're in severe pain, but it's something that you, with expert input, you can practice and master, can sort of go a long way to turning down the volume on some of that pain. Formal psychological assessments can be helpful. They're not for everybody, but particularly where there seems to be a real connection between pain causing low mood or low mood in turning the volume up on pain, then formal psychological input can be really valuable. Physical activity, every doctor you have talked to will tell you to exercise more, and I think that's very easy to say and often very hard to do, particularly when you're in pain and particularly when you've got fatigue and you're experiencing side effects from chemo. Getting out there and doing exercise is often doesn't feel like a very realistic goal. So I always talk to people about trying to find something that they enjoy doing. It doesn't have to be a particular type of exercise. It has to be something you enjoy, and because that's the thing that's going to predict whether you're actually able to do it and actually able to get there. Doing things with friends, just starting slow, starting at a very achievable level, not trying to hit the gym suddenly when you haven't been there for 25 years. Just gentle walking, getting outside, getting some sunshine on your face, that sort of thing, I really encourage people to do. TENS machines can be helpful. Again, not for everyone. Some people love them, some people hate them, but this is like a electrical nerve stimulator that you stick pads on your skin, and physiotherapists can often teach you how to use those and encourage and sort of show you how to best apply them. And then acupuncture can also be helpful, but in the setting of myeloma and chemotherapy, it's really important you discuss it with your doctor to make sure it's safe for you, because if your blood is not very good at clotting, then getting a needle stuck in your skin might actually cause you more of a problem. So definitely discuss that one before you go down that path. Medications, I think it's the sort of key things I would highlight from this slide, there's a lot of information here, is that using paracetamol, unless there's a reason that you can't use it, even though on its own it probably won't make a huge amount of difference to your pain, if at all, there's lots of evidence that by using regular paracetamol, the other medications you use will work better, and therefore you can use them at lower doses and therefore have less side effects from them. So I encourage everybody to use recommended doses of paracetamol, obviously in discussion with their doctor, if they've got a chronic pain problem. The other medications your doctors might use to manage your neuropathic pain include medications from various sort of groups. So some of them are antidepressant medications, some of them are anti-seizure medications, and they all work by acting on the chemical signaling from nerves to try and turn down some of those pain messages. I think with all of these medications, they do have side effects, and some people find that that is the reason they can't get good control. So I always recommend that people start on very low doses and increase them very slowly. And this helps with side effects not being as problematic, although it does, of course, make it a longer and slower road before you get the benefit. And so patience is required. It can take a few weeks before you really know whether each dose change has made a difference to your pain levels. And I also encourage people to really have some objective measures. When we're in pain, it's very easy to only be able to remember what, like if I've had a really bad day of pain the day before I come and see my doctor, I'm going to say, oh, my pain's terrible, even if I haven't necessarily had a lot of pain in the last month, because pain is very all-consuming and really occupies a big space in our brain. And so I like to keep diaries and sort of set goals and track things, because if you have one really bad pain day, but that's the only one in 6 weeks, then that's better than having bad pain, 3 or 4 times a week. So setting those things down on paper can help us kind of see where we're making gains and see what's working and what's not. And then also it's worth talking to your doctors about topical treatments, such as capsaicin, which is like from a chili plant, and lignocaine, which is a local anesthetic, and these things can help with localized pain and have sort of less in the way of side effects, because they're not going into your bloodstream in the same sort of doses that a tablet will. The most common reasons I see that people don't have success with medications with neuropathy pain is sort of not using paracetamol, starting with really high doses and then getting side effects and stopping it, or starting on really low doses and then never increasing them, and so not taking enough. Taking it for 3 days and saying it didn't do anything, and stopping and not giving it a chance to sort of give that 2 to 4 weeks lead in that you need. And then also sometimes, and often not because the person taking the medication has done the wrong thing, but because they've been given some sort of unusual advice. Sometimes some of these medications get prescribed as sort of as needed. So, and they don't work like that, because they change sort of nerve signaling over time. And so taking a sort of an antidepressant or an anti-seizure medication for neuropathic pain just kind of when you get your pain is not going to, they don't work like a Panadol where half an hour later you get relief. They need to be taken regularly to have their intended benefit. I think it's also, and this is a bit of a sort of disheartening thing to put on here, but sometimes pain cannot be completely suppressed, and that can be very frustrating, of course. But sometimes that sort of expectation that a medication will make the pain go away completely, I think, can set people up to keep trying new things, searching for that thing, rather than sort of benefiting from an improvement in pain and having some more realistic expectations. And they're people who I really would encourage to look at some of those non-medication based pain strategies, because the medications we're not there yet, unfortunately, in terms of having sort of a silver bullet for neuropathic pain in terms of a medication. So then in terms of muscle cramps, this is another really common symptom that my neuropathy patients talk to me about, and it's something that's not really well dealt with in the literature, in the science. Like, there's not a lot of research around what to do about nerve-related muscle cramps, and so the advice is really restricted to some very sort of generic statements, but these are things that are helpful. So making sure you're adequately hydrated, obviously not I'm not suggesting anyone goes out and drinks 8 litres of water a day, but just making sure that you're not thirsty and you are keeping up adequate water. Reducing or avoiding alcohol can also help, as that sometimes is related to dehydration and also muscle cramps. Doing gentle stretches, particularly before bed. Often people get muscle cramps at night time in bed, and it disrupts sleep and can be very painful. So doing stretches before getting into bed, particularly stretching the muscles that tend to cramp. And then also massaging during a cramp can help, and stretching it gently can help relieve it. Sometimes a nice warm bath or a warm shower before bed, and also making sure you're not cold in your bed, can help muscles to not cramp as often. People can sometimes you'll have people recommend that you take magnesium or that you take quinine or something like this for cramps, because they're sort of people think that they help with cramps. I think it's important to be cautious about these medications, particularly when you've got other significant health issues going on, such as myeloma. So if you had low magnesium levels on a blood test, then certainly a magnesium replacement is very reasonable. But if you're taking it and you don't need it, it can actually cause side effects, including sort of getting low blood pressure, feeling nauseous or headachy, or even diarrhea, which, given that we're already concerned about nutritional deficiencies, we're really not wanting to add to that. Quinine is not recommended. It can cause low platelet counts, which many of you know are the part of your blood cells that are involved in clotting, and very important. And so it can be very dangerous to use quinine, particularly in the setting of having chemotherapy for a blood cancer. So there are some other medications that people will sometimes try for cramps. None of them have very good scientific evidence behind them, but I think if you are having a lot of trouble with cramp, it's worth speaking to your doctor about what the options are, and they can talk you through the risks and benefits of those. Again, another busy slide, managing autonomic neuropathy. It depends on what the symptom is that is bothering you, but I've just got some of the sort of highlights here. So diarrhea, it's the first thing when someone tells me that they've got diarrhea and I know that they've got an autonomic neuropathy, I want to make sure that it is truly due to the gut sort of moving too quickly, and not due to probably a more common problem, which is someone who's very severely constipated and then gets loose stools, because that's the only sort of stool consistency that can get around the stuff that's all backed up. So a bit of a graphic description there, but it's what we call overflow diarrhea, and it's loose stools sort of coming around stuff that's all stuck in there. And actually the treatment for that type of loose stool is to actually use laxatives, which can be a bit counterintuitive. So and a careful sort of history taking and trying to work out what the sequence of events has been can help work out which is which. Sometimes we need to do even an abdominal x-ray to just have a look and see if we can see if the bowel is all backed up. So either increasing fibre, or even taking some medications to slow down the gut if we think it's truly diarrhea, or laxatives if it's constipation. If the stomach isn't emptying properly, then some sort of strategies like just eating small meals, and small meals more frequently, rather than having a really big meal that then fills the stomach up and makes you feel awful and vomit. Avoiding sort of things that are very high fibre or very high fat, which are kind of a little bit trickier for you to digest. And then speaking to a dietitian can be very helpful, and certainly is recommended if you're experiencing weight loss in the setting of this. Sometimes medications can sort of stimulate the stomach to empty more quickly, and so those can be useful. Difficulty with bladder can be tricky, because the most common type of bladder problem is a bladder that isn't very good at emptying, and so sort of retains urine and is therefore more prone to infection. And so there are things like urinating on a schedule, so not waiting till you feel the need to go, but just going sort of regularly to try and avoid that sort of urine building up and becoming a place where bacteria can live, and in some situations self-catheterization. I've just got a message that I'm going over time, so I will move on. Apologies. So autonomic neuropathy with low blood pressure, there's a few things there, and I'm very happy if people want copies of these slides later to have a look at, they can do that. but it's around trying to increase your salt and particularly thinking about compression stockings or tilting the bed up. And in terms of looking after your feet and your hands, physiotherapy and podiatry are the really big key points here, and making sure that we look after numb feet and don't let them get injured when we can't feel it. I apologise for taking too long to talk. Vitamin supplements I really only recommend if you have a confirmed deficiency, and making sure you're not accidentally taking too much B6, which is a common ingredient in many multivitamins, and it's very easy to overdo, and that can be harmful to nerves as well. If you're taking any additional sort of herbs and supplements, then certainly talk to your doctors about it, particularly if you're on active chemotherapy, because these are often used because they actually do something, and so they can interact with your chemo and make it either less effective or more toxic, and it's really important that you discuss that with your doctor. And so medicinal cannabis, that's another one that commonly comes up. Commonly people will ask me about this because they hear on the grapevine that this is really good for nerve pain, and they want to know whether this is suitable for them. I think it's certainly worth looking at, and there is some evidence that it is helpful in nerve pain and also in chemotherapy-related nausea and vomiting. But it's important to note that although there is evidence, it's not recommended as the first thing to try in those situations. And it's unfortunately not on the pharmaceutical benefit scheme for either of those indications. So there's a significant cost associated with it, which at the moment is about $100 a week. And it's important that I mention, and I mention this to all my patients who ask about it, that procuring cannabis products online from other sources can be harmful because they are not regulated. You don't actually know what is in them. They might not have anything in them, and it's not legal to import them. So just always something that I mention. If you are interested in learning more about medicinal cannabis for nerve pain, the NPS Medicine Wise website, which I've got the link here for that, is a really good resource, and you can find more information about that. All right, sorry, let's keep going. So in terms of preventing progression, if you already have developed neuropathy, and unfortunately nerves, although they can heal, they do it very, very slowly, and in the setting of ongoing active medical issues, they often don't do it particularly well. So what can you do to stop your nerves getting worse? So the main things really is making sure there's not some other factor going on. So diabetes is really the big one that you want to get good control of if it is in the picture, and B12 deficiency is the other really common one that it's important to check for. Avoiding other medications that can cause nerve damage if that's possible, and unfortunately the list of those medications includes some of the chemotherapy agents used in myeloma, as we've discussed. Maintaining a healthy, balanced diet is the best way of making sure that you're getting all of those nutrients and micronutrients in. And if that is difficult because of other issues, then talking to your doctor about the need for vitamin supplementation, and then reducing alcohol use as well. So as I said earlier, in the presence of neuropathy, we know that makes it worse. All right, in terms of current research at the moment in South Australia, which is where I am, there's nothing locally happening on the trials register that I can find. But there are a few things that are on the Australian New Zealand Clinical Trials Register, and this is a really great place to go looking if you're interested in finding out what is around and looking to participate in any clinical trials. If you go to this website, you can put in various search terms for particular medical conditions or particular groups of people and find trials that might be relevant to you, and they have the contact details there for the people running the trials. And I think in summary, I'll just summarise. I did go very quickly through some of those slides, sorry, because I panicked about my timing, but obviously very happy to answer any questions or revisit slides if people wanted me to. So we know that neuropathy is common in myeloma, and optimising nerve health by managing the things that we can control, such as diabetes and alcohol, is important to minimise symptoms. In some cases, dose and treatment regimens may need to be adjusted, and that will be weighed against the risk of treating the myeloma less effectively. Treatment of symptoms, particularly the pain symptoms and the autonomic symptoms, can really improve the experience of living with neuropathy, even if the neuropathy itself can't be fixed. And that's using a combination of sort of lifestyle measures and also the non-drug pain management, as well as prescribed medications. Vitamins and supplements very frequently recommended by well-meaning friends and family for people who have neuropathy, but it's really important to make sure that you discuss those with your treating doctors, because some of them can accidentally harm you, such as B6 supplementation, which I see probably 1 or 2 cases a year of people who have B6 related neuropathy from accidentally taking too much. And medicinal cannabis can play a role in neuropathic pain management, but only really should be considered where other measures have failed. And as mentioned, more information on the NPS Medicine Wise website about that. So thank you, and I'm very happy to take questions or revisit any slides that I might have inadvertently skipped over quickly in my time-related panic. Sorry about that.
That was excellent, Jessica. Thank you so much. Such an informative session, and you actually answered some of the questions that had come through in your slides, particularly on the neuropathic pain and management there. So thank you for those tips. We did have one with an autonomic symptom question, in particular relating to lenalidomide and some night sweats that they're getting. Is there anything you could touch on there in terms of management or prevention?
Yeah, so night sweats is tricky because it's probably not just related to neuropathy per se, and is probably multifactorial. Generally, for night sweats, and obviously it might be medication related, it could be even myeloma related. Like, there's lots of things that could be contributing, and the advice is pretty sort of basic stuff. But for night sweats, I usually just encourage people to make sure they've got cotton sheets and cotton pajamas, make sure their room is cool, make sure they've got a fan on, and just trying to reduce their temperature. But unfortunately, there's not really any sort of medication or anything else specifically other than trying to keep cool. Unfortunately, in a night sweat, what will happen is it will happen even if you're cool, and then you'll be really cold because you're now covered in water. And so, yeah, it's a tricky one, but I don't have any very clever solution for that one, unfortunately. Other than avoiding synthetic fabric is the only thing I can suggest.
That's a great tip. Thanks so much. Encourage people to look back through the slides, and you can always send your questions through to us at nurses@myeloma.org.au. Thank you very much again for your time, Jessica. We really appreciate you being here. Thanks so much.
Thank you.